Be sure to review how F-18 FDG gets localized and trapped in the body. Know that cancer cells use glucose at higher rates than normal body cells, and that FDG is basically a synthetic mimic of normal blood glucose, which is blood sugar, and our main source of glucose or sugar in our body is from food. However, with all that being said, sugar from food does not necessarily feed cancer. That's one of the main questions that patients having PET scans, after you kind of explain the test to them, they're going to ask you that. They're going to say, well, if, cancer cells take up sugar, should I not eat sugar? They're also going to ask you, is it safe for them to have this injection? So, the next few slides talk about glycolysis and phosphorylation and how that's a lot different for FDG versus normal glucose. After the FDG dose has been injected, the body doesn't necessarily pick FDG over normal blood glucose, so that's blood sugar. We're going to talk about why it's really important to check the patient's blood sugar before you inject them, and there's several reasons, but this is a big theme or reason for that, is because if the patient has a lot of extra blood sugar in the body, that might take away from the amount of FDG that gets taken up into the cell, and then therefore your uptake would be poor. It is super, super, super important to know the normal biodistribution of F-18 FDG. So in every patient, the brain is going to be pretty intense because the brain uses glucose as an energy source. Other organs will be the liver and the heart, and those are kind of variable. So the liver processes glucose and also works with the pancreas and kind of the absorption of glucose and creation of insulin. The heart is a muscle, so it beats and it uses glucose constantly as a fuel source. The kidneys, the urinary tract, and bladder are all going to show up variably hot also, because the urinary tract is how FDG gets excreted through the body. So not so much in feces, but more so in urine, so similar to bone scans. But just keep in mind that this is kind of the main organs and areas of the body that are going to show, pretty intense to moderate activity for every single patient. All facilities have very different protocols as far as how long the patient should fast before a PET scan or before the F-18 FDG injection. Most of the literature and textbooks say it has to be at least 4 hours of fasting, which means nothing, no food, no liquids by mouth, with the exception of a small amount of water. Ideally, even, if they can tolerate it, you wouldn't want them to have water either. That more so plays into the CT injection, because they might choke or vomit if they have anything at all in their stomach. So anyway, back to the PET part. The reason for that is to kind of lower the body's natural blood sugar levels. Again, that way the FDG can be maximized for uptake. Just like a bone scan, you want the patient to void or go to the restroom right before you get them on the scanner. That is to empty the bladder, similar to a bone scan. The bladder can be lined heavily with activity, FDG activity for a PET scan, which can obscure or kind of block a lot of the other organs in the body, especially in the pelvis. It also can cause a bladder artifact. If the bladder is super concentrated and full of hot urine, it'll cause streaks all the way through the images. It can cause problems all the way up to the head when you're scanning. So just be sure to have your patient void right before they get on the scanner. The dose rate for adults kind of varies based on your facility. So some places use just like a standing dose order for everybody, no matter how much the patient weighs. Typically, that's going to be between 15 and 18 millicuries. And then some facilities use the common formula of 0.14 millicuries per kilogram of body weight. So that's what I used when I was in my clinical practice. So your average, 200-pound adult, it's going to be, I haven't done the math, so don't, quote me on this, but around 12.5 millicuries. And that's pretty standard. That's pretty good amount of dose. That'll get you good quality images. So of course, as the patient weighs more, you'll give them more. Most facilities have a cutoff limit. At the place I used to work, it was 18 millicuries. So no matter how big your patient was or what, you could not inject them with more than 18 millicuries. So if that did accidentally happen, you would just have to write a report and have a radiologist sign it, explain what happened. So maybe your residual was, less than you thought it would be, whatever the case may be. Pediatric dose also has a range. It's a little bit less, 0.1 to 0.14 millicuries per kilogram. And think of how tiny kids and babies are. So typically the dose ranges between 1 to 8 millicuries. So FDG typically sticks to IV lines or the plastic part of the catheter, so you definitely want to flush it as much as you can, as much as it'll let you and as much as you have time for. But then keep in mind that you want to try to limit your exposure to the patient, so you want to work quick. Between 20 and 30 milliliters of saline is ideal to flush the catheter and make sure it gets all out. That way you have an accurate injection. After you inject the patient, the uptake time for FDG is pretty standard at 60 minutes. So you want the patient to relax in a recliner for about an hour. And when possible, you definitely want to cover them up with warm blankets. Normally ask them to dress warm, get them comfortable. You don't want them moving a whole lot. We'll talk about that, I think, in 2 weeks. Kind of the consequence of after you inject them, if they start digging through their purse, or if they're like, oh, I gotta go to the bathroom, or if they're shivering, whatever the case may be. So you really want to set them up before you inject them. Let them rest for about 10 minutes just to try to get comfortable and warm, and then you inject them, and then you let them sit there for approximately 60 minutes. So 60 minutes is what you guys will see in clinic, whether it's at Baptist, West Clinic, anywhere else you may go. So in addition to the other sites of normal biodistribution that I've already talked about, there are other sites or organs or tissues that may also take it up, and this can be totally normal also. It just more so depends on patient behaviors. So for example, salivary glands are one of those examples. If the patient's hungry, which they will be because you've had them in a fasting state, maybe they're salivating, or their mouth is dry, they're licking their lips a lot, that would cause a lot of extra uptake in the mouth area. Another example is of the stomach. Again, if they're hungry, their stomach might be churning, rumbling, and it's actually moving, and that could cause uptake as well. So just be sure to familiarize yourself with all of these, this list of places that variable uptake can sometimes be normal. So of course, we can do PET scans on breast cancer patients, and breast is listed here. I'll give you some examples of kind of what we mean, but here we mean low levels. So just maybe outlines. If you look on this slide here, you can kind of see 2 areas of the breast tissue that might be considered a little hotter than background. You can see on the image, and that could be caused from a number of reasons. It could be from recent breast stimulation, putting on your bra too tight could be pushing them together if the patient's been breastfeeding, whatever the case may be. Definitely be sure to know the difference between whole body PET scans and total body PET scans. We covered this in a previous lecture, but just be sure, because you want to know proper terminology when you're doing PET scans or when you're discussing PET. So whole body PET scan is from the skull down to the mid-thigh. So often we call this eyes to thighs. Total body is what you would think of. It's your total body from your head down to the tip of your toes. So total body PET scans are normally only done for like skin cancer and for multiple myeloma, or myeloma, which is a bone cancer or bone marrow cancer. Whole body PET scans are typically done for all other types, so lung, breast, gastric, head and neck, anything you may think of. So just be sure to know the difference. Positioning in PET is super, super important. Unless it's a total body skin cancer scan, you want the patient to have their arms raised, and this is for a few reasons. One, you'll get better images, or you'll have a better view of the chest anatomy, so your lungs, heart, esophagus. And two, if they're down, they can actually cause truncation artifacts. So hopefully you guys talk about that in CT. But basically that is where all of your anatomy doesn't actually fit into your digital field of view, and it causes really poor image quality streaks. I will show you an example of this later when we talk about artifacts. I think I have an entire lecture on PET artifacts. But for now, just know the importance of leaving the arms up. So the next two slides are showing some clinical images before the patient had treatment and then after. So for both sets of slides, or both slides, these are the same patients before chemo and then after. So for this slide, this is a lymphoma patient who had pretty diffuse or spread metastatic disease all over the body. They definitely had chemo because it's so widespread. It wasn't just one organ or one part of the body that could have easily been irradiated with radiation therapy. They could have also had radiation therapy. If I were to guess, it would have been probably to one of the hot spots in the chest, but definitely had chemo. So when we look at the post-therapy, even though these are in different sections or planes of the body, you can see a lot of improvement. There's a lot less hot spots. When we look at the post-therapy F-18 FDG scan image, we really see our normal variants. So the brain got kind of cut off, but if they would have scanned up high enough, you would see brain activity. There's heart activity, some faint bone activity, kidneys, and then a very hot bladder. So that's, a good response to the therapy. Again, this slide is very similar, so pre-treatment, post-treatment, and I guess the point I wanted you guys to visually see with these images is the importance of PET scans before the patient starts treatment, so initial staging, and then after they've had treatment. We'll talk about these and look at a lot more images later in the course in 2 or 3 weeks.